Good evening, sir.
Good evening. Good evening, all. This is Sankarasubramanian, physiotherapist from Sri Samraj Physiotherapy Center, Dindivanam, Tamil Nadu. Hope you all are fine, and our physiotherapy students are preparing for their oncoming exams. Thank you for everyone for taking time out to register and also participating in this webinar. Today's topic is ankle and foot imaging for physiotherapists. Will be taught to us by Mr. Sathya, Sankarasubramanian, sports physiotherapist from Corio Bay Health Group, Foot and Ankle Rehabilitation, Australia. This webinar is available in our Fitness and Rehab India YouTube channel. Those who are viewing it can post your doubts, queries in comment section. We will read it in our Zoom meeting at the end of the session. After the session, the certificate link will be shared for the registered participants. You must attend the MCQs asked and then download your certificate from our website. Now, I welcome Dr. Rupesh and our resource person, Mr. Sathya Sankarasubramanian, to commence the webinar. Mr. Sathya Sankarasubramanian, please, sir.
Thank you so much. Thank you for the intro, Chandru and the whole team, Rupesh, Tona, and everyone. This is my second topic I'm talking after the big webinar, webathon, which Chandru conducted, which was a great success. I was able to be part of it and creating the world record with the whole team for the great profession, physiotherapy profession, the leading researching field in the whole world of medical and medicine and sports medicine areas. I wish all the physio students a great success in your future career and best wishes from down under. I'll share my screen.
Yes, please.
I hope you are able to see my screen now.
Yes, sir.
Okay, beautiful. So today's topic is on foot and ankle radiology for physiotherapists. I'm Sathya. I'm working here in Australia as a sports physiotherapist for the last 13 years. I graduated from India, from Chennai, and I've been in sports and sports related areas or even in sports medicine for the last 18 years now. I thought of giving you a brief outline how important imaging for physiotherapists is. And my area of special interest are in foot and ankle imaging and foot and ankle management as well, and the sports as well, post injuries or post operative areas. So today's our overview is on the outline is on, we must understand the whole clinical examination, how much we have done our clinical examination to understand what foot and ankle problems we are dealing with and how much of areas that we have to assess and what we need to do further. So in our topic today, we'll be overviewing on various modalities relating to X-ray, CT scans, MRI, ultrasound, of course, in nuclear medicine area also. So, so initially, you can see this is a bit of a busy slide there, where we can see all the different modalities that we have that we can use for foot and ankle radiology as such on the whole. Like X-ray involves bone, joints, fractures, and we can do weight-bearing X-rays and non-weight-bearing X-rays also. Ultrasound, which obviously involves a lot of superficial injuries that we can go and detect, for example, ankle sprain, tendon injuries, tendon pathologies, joint pathologies also, if it is superficially involved, for example, any talar dome lesions at the front of the talus, where if a person is able to plantar flex, plantar fasciitis, any of those areas we can find using ultrasound. Then with the CT, we can detect fractures, stress fractures. Also, in a 4D view, we'll be able to look at the whole morphology of the foot and ankle on the whole. We can look at systemic illnesses like gout, and we can also perform weight-bearing CT, which I will be explaining in further. With respect to MRI, we'll be able to see the general outline, including the soft tissues, to some extent the bony pathologies also. But majority of the soft tissues involves your tendons, ligaments, cartilaginous areas, your muscular areas, If there is a bit of occult fractures and a fracture which can't be seen in a normal X-ray, but you have to go and look into further investigation, for example, a stress reaction, stress-induced fractures, a small fracture which you can't see in an X-ray because of overlying or overlapping shadows. CT and the SPECT, which involves joint fracture infections, can be looked into. Any of the intervention therapies are nothing but any PRP injections, corticosteroid injections to reduce inflammation. If there is any stiffness in the joint, hydrodilatation, if there is a stiffness in the joint, especially the lunge testing for ankle. And ultrasound is very important in those areas, and we can use it for interventional management also. So to understand X-ray, how X-ray works, it is like an energy form similar to light and radio waves. X-ray has enough energy to pass through our body. The rays are not absorbed, and the rays that are not absorbed creates an image at the back on the film, and that's what we are seeing as an X-ray. The amount of X-ray that is absorbed contributes to a person's radiation dose. The person who is exposed to radiation, for example, that technologist who is there in a radiography area and he has been exposed to those radiography elements that's been coming out of the machine. So exposure plays a major role. So we must understand how much the person is able to or allowed to expose themselves. There are many bodies which we will be seeing in the few slides later. They control and they will be able to tell us how much the person can expose themselves or not. The way it is measured is through millisievert. It's like MSV. That's what majority being used, but it can also be measured in the units like RAD, like a RAD, REM, Roentgen, sievert or Gray. These are all the different kind of measurement units that we use for X-ray identification. The effective dose, when we say a person who has had an amount of dose, and if the dose goes beyond that level, especially children who are exposing themselves to repeat X-rays or a lot more X-rays or a CT scan, repeat CT scans, there is a chance or a possible side effects for this to happen. Cancer maybe in the later in life. But again, it is not all of them will be ending up in that problem, but a small amount of people can end up in such a problem. So we must understand how much is important for a person to be exposing to radiography. And most of the time, any of these X-rays, they are highly sensitive. X-rays of the tissues, organs absorb, especially the body absorb a lot of X-rays, especially the organs in your visceral area, and they are very sensitive to radiation also. So we must understand how much we are exposing the person. So there is something we call it as a natural occurring background radiation, which is very important, how much we expose to radiation in our general life. Okay, for example, a cosmic radiation which is coming on the outer space. When we go on the heat area, it happens to us. Normally, for an average person who receives is about 3 millisievert per year, which is normal with respect to cosmic radiation, or which is like a background naturally occurring radiation, which can be increased to approximately 1.5 MSV in high altitude. So from 3, it becomes 4.5 or 5. If someone who is living in a higher altitude area, say, for example, who are living in mountainous area, Himalayas, for example, because of the exposure for them to receive those ultraviolet rays is much more harder. In Australia, where we live, for us, the ultraviolet rays are much more exposed because there are certain areas or the pockets of areas we don't have ozone layer covering completely. So that has an impact on us most of the time. So skin-based problems, skin-based cancers are highly seen in Australia. An aeroplane trip, we must understand there is an amount of cosmic radiation that happens, right? So about 0.03, if you're going to go end to end, say one end of the continent to another end of the continent, there is a chance that that could happen. You're going to fly at least about more than 10 hours that can cause that. There are other sources of naturally occurring radiation, which is called as radon gas, which obviously seen in quite a few areas. The radon gas is areas that is more filled with uranium, so that can emit that much amount of gas on them. So that is another thing we must understand. But roughly, So these are all the data that I have obtained from Australian government as well from the Government of India Atomic Energy Regulatory Board. I was looking through and found out that these details are there in all these websites. To understand, all of the physiotherapists must go and look into what type of radiation that we can understand and what is available, what is allowed, what is not allowed. These kind of information is given in all these bodies. So with respect to radiation dosage per year, I've given roughly annually a person can receive up to 1.5 millisievert, but X-ray of an ankle basic view, which is basic 3 or 4 views, that involves your AP view or a PA view or a mortise view or a lateral view, they can comprise maximally about 1.5 millisievert, 0.01 millisievert only. But a bone scan involves higher amount of radiology, higher amount of exposure. So many times the X-ray being emitted, and so many times it is been absorbed through the body. So it can go up to 6 millisievert. And CT of your ankle, it's only 0.1 again. 0.01 for X-ray, 0.1 for foot and ankle. And a 4D CT, which is again very low dose CT scan at a lower emission of X-ray as well, so which is only 0.02. A weight-bearing CT can be up to 0.05, and MRI and ultrasound is totally zero. They are non-ionizing radiation method, so it doesn't emit any X-ray or radiation dose for a person. You can see in general how radiation in general life is affecting each and every person, and that's what this diagram shows for all of us to understand what is naturally occurring under man-made radiation. In the man-made radiation, like an annual dose per person is up to 20 millisievert. Okay, an average effective dose from a CT scan can be up to 6.6. Okay, so we must understand how much a person has to go through repeated CT scans that can have a potential harmful effect for them in the future. So a radiation dose, which always must be taken into account, but should not prevent from us choosing the correct technique for our assessment. If we feel that there is a person who's having a navicular injury, or you suspect for an end-spot navicular stress fracture, if you think that they have to be having a CT scan, better you send for a CT scan irrespective of the age, because you need to understand what the problem that you're dealing with, whether it is a complete fracture or it is just a stress fracture, or is there some other structures involved, is there is a dysfunction is happening, or is there is dysfunction during movement. And you can go for movement related or 4D related CT scans also. We must be able to choose the right test. Quite often in India, we rely on doctors and specialists, doctors or orthopedicians or sports physicians to issue a referral for any of the investigations, which I think the physiotherapy body must all of the chance for the physiotherapist to prescribe certain basic levels of X-rays and ultrasounds and MRI scans involving sports or sports-related injuries must be taken into consideration, I believe, and they must move forward to approach this towards the medical council also. So this will understand or give us a chance to read more about radiology, allow us to learn more about injuries and how we can manage those kind of conditions, especially musculoskeletal related conditions. So MRI and ultrasound is most often chosen for children, young adults and pregnant women due to the chance of exposure and avoiding those exposure to them. You can allow them to have multiple tests. Sometimes a low dose CT scan, like sometimes a SPECT CT can also be used, but it can't, it cannot be disregarded completely, because if you feel like it needs to be taken, it needs to be taken. With respect to ankle and foot X-ray, we must use the Ottawa ankle rules, which has about 97 to 98% of sensitivity, and we must have, it's a group clinicians strategy or tool. What you can do is, for an ankle, if you suspect a person who have had an inversion-based ankle injury, what you're going to do is to feel for certain basic 3 areas: the tip of your lateral malleolus, the posterior edge of the medial malleolus, or if a person is unable to weight bear, at least or able to walk, not even 4 steps from the acute time of the injury on field or wherever they injured themselves, to the emergency department where you're going to think that they need to have an X-ray taken. So it's better to do an X-ray. If you feel like all these or any one of these is positive, better to have an X-ray taken of 3 or the 4 views that I mentioned before. For the foot, especially the same point tenderness at the base of the 5th metatarsal. Base of the 5th metatarsal involves where the peroneal tendon comes and inserts. We will see some diagrams a bit later. Whether there is tenderness there, or if there is point tenderness on the navicular area or the end spot we mentioned as before, and if a person was unable to weight bear at least for 4 steps, and then it's better to have an ankle X-ray taken. This strategy quite often reduces the exposure for a person to go for X-ray unnecessarily. So the Ottawa ankle rules helps us or guides us to move forward to whether the person needs an X-ray or not, or further investigation or not. Okay, especially there has to be caution to be applied for children under 6 years, because you're not sure, because their understanding about the problem or giving you feedback about the injury sometimes is very hard, because they don't realize and they are in a kind of a danger mode, and sometimes we don't have enough data to say that to follow Ottawa ankle rules for all the other people. So be cautious on that side. So with respect to foot and ankle X-ray views, normally the standard views are the AP view or AP mortis view, and then the lateral view, horizontal beam lateral view again on the horizontal way, and the other one is vertical way given, and then an anterior posterior stress view also is used. On the foot series, a dorsoplantar view, that's a DP view we call it as, and then the oblique view is used, then the lateral view, for example, to look at the arch of a person, or you look for a calcaneal spur, you want to rule out what we are dealing with. So those lateral view will be much more better. And then the weight bearing dorsoplantar view. So that's again tells us if there is, for example, a Lisfranc injury, a Lisfranc structure which involves your first and your second base of your metatarsal closer to the medial cuneiform. So if there is those structures involved, and weight bearing of the lateral view also can be performed to understand again if there is a collapse happening, is there is a problem with the talonavicular joint or a calcaneocuboid joint, or even with the naviculo-cuneiform joints, or even further into the tarsometatarsal joints. If a person who is suffering with osteoarthritis of the first tarsometatarsal joints, these areas can be ruled out if there is a problem with, or if we can use these views. So foot and ankle X-ray views, normally we can use also a calcaneus series to understand on the posterior aspect of the heel, to look at the axial view of the calcaneus, or even a lateral view of the calcaneus. Quite often an anterior calcaneal process, which we call as ACP, if there is due to an inversion injury, quite often that is missed, or sometimes it over smudges between the different overlapping of the bones. Quite often it is not visible. So due to the shadow that is present, and if there is tenderness from the bottom of the midfoot and the hindfoot junction, then it's better to go for a calcaneus series, or sometimes even you have to go for further scans like MRI or even a CT scan. Toe series are basically anterior posterior. Again, some oblique views can be taken, some lateral and the sesamoid view to understand if there is a person with a bipartite sesamoid or a sesamoiditis, or tarsometatarsal injuries, metatarsophalangeal injuries. They can be ruled out using these views. So X-ray is always the gold standard we try to follow for any foot and ankle problems. So all the X-rays that I have provided here is all my patients, and some of them have been taken from websites as well, but I've ensured that all my patients' X-rays being used in this platform. So here we are seeing My suspicion was this person, whether they have got a Lisfranc injury. A Lisfranc injury, as I mentioned before, an injury that is involving between the base of the first and the second, and involving the medial cuneiform bone, also the ligament that connects this area. So why we are doing this initial X-rays to rule out any suspected bony and joint pathology. Most of the time, the indications are fracture, infections, joint issues, any joint problems like degeneration, or if there is a joint osteophytes formation, you want to rule it out. Any stiffness related to range of motion, if there is a locking, is there any presence of foreign body there, you have to rule it out. So better to use the X-ray for that. Bone and joint anatomical alignment, you want to look at the anatomical alignment, whether if there is a collapse that is happening, especially on weight bearing X-rays. And bony and any tissue pathology, if there is any cyst, any tumor, for example, a schwannoma or a fibroma, which is happening at the plantar fascia, fasciomas, or fasciomatosis, you can reduce all these, or you can understand through an X-ray whether there is any problem that is evident or present. If there is any surgical fixations being done, any screws, any open reduction internal fixation, or any other methods of management, which we're going to see in the next few slides. So the X-ray of the foot and ankle, we have to understand why we do. Is there any congenital abnormalities like equinus or equinovarus or talipes equinovarus, or sometimes a fracture malalignment? If there is any malunion have happened, or a wrong union or a non-union have happened, we have to understand those areas. Any stress fractures, quite often it's pretty hard to figure out stress fracture, but we will be able to understand if there is a periosteal inflammation, which is the cortical area of the bone, especially the shaft of the metatarsals. If there is a small separation that is happening, which we can see as an edema presence on the bony lining, in a digital X-ray, we'll be able to see this, and we can differentiate this. And any ongoing degeneration, which is any arthritic formation or reduced joint space, which we have always seen on the knee joint, for medial meniscus, if there is any or medial compartment joint compression that is happening, whether any arthropathy, any kind of arthritis or chronic arthritic presentation. If there is a presence of any mass, like any cancerous mass, any bony mass, any bony inflammation, bony swelling, bony internal presentation, like a nodules or nodes, can be looked at it. And we can also do X-rays like a non-weight bearing and weight bearing also, as I mentioned to you before, like for example, Lisfranc, to understand ankle gata, sinus tarsi, syndesmosis area. So ankle and foot, as an X-ray review, on this X-ray, we are able to see this is a young person. Here we are trying to look at the growth plate, how the person's growth plate is forming. Is there any growth plate fractures are present, any Salter Harris presentation is present there. You have to rule out, is there any other congenital problems? As I mentioned before, any anatomy and malalignment problems, any joint degeneration and spacing at the early age, especially for kids. This is an AP view and a kind of a modest to oblique view as well, is what is presented here. I want to show you a video how X-ray works on the whole. In this, you all will be able to listen to this. This is from the National Institute of Biomedical Imaging in America. So they have put this 60 seconds video. I would want you to listen to this.
There is no audio in this, Sathya.
Oh, sorry.
Also, you can maximize the screen. You can explain it.
Yeah. Okay. So what it shows is basically how an X-ray is taken, how the X-ray film goes through your body, and whatever that is absorbed, and the shadows is created by the soft tissue, and automatically the bones become exposed. Now we are able to see that whether there is a fracture or not. That's what it is explaining about this, how the X-rays do work. For example, in this view, I have shown what is there. Like here, we are able to see the person who has an osteogonum injury there. We are able to see at the back side. The osteogonum is nothing but the lateral process of talus that is injured during the process of, say, an ankle sprain. And we are able to see that this piece of the bone is starting to hang out. Here, this person, they have got a partial healing. However, there is more happening to this at the same time. So in this view, we are able to see how an ankle mortise is looking and the talus dome, osteogonum. If there is a fat pad involvement, a Kagas fat pad is the one that structures behind the ankle joint in front of the Achilles tendon, and joint effusion, whether if there is anything, if there is a bony and joint problems are present, we are able to see in this view also. Just one moment.
Yes, no problem.
For some reason, hang up on me. Are you able to see now?
Yes.
Okay. All right. Here I am showing you about a syndesmosis injury, how a syndesmosis injury happens and what happens in a syndesmosis injury. Syndesmosis is nothing but the anterior inferior tibiofibular ligament that protects your tibia and fibula and forms a hinge for the talus to articulate. So this ligament, along with the interosseous membrane that is present, thickens at the front of the ankle, in the middle of the ankle, not ankle, just above the ankle, between both the fibula and the tibia, and at the posteriorly as well as the posterior inferior tibiofibular ligament. They are responsible for holding the ankle joint together and forms a mortise like a hinge, so that the talus can easily articulate underneath. So if this is called as a high ankle sprain also, if a person who rolls their ankle and they have got some specific swelling above the ankle, then you can rule it out for a syndesmosis injury. Here, an injury that is shown how the injury looks in real time. You can see we call it as a gutter space. The gutter space is nothing but, a gutter is nothing but like a cave, like a space. If you invert it upside down, that's what you see. And the space between the talus and the presence of the medial malleolus, you can see the gutter there. So that space naturally increases as the time moves on due to this injury, and starts to push the talus onto the tibial plafond. Thereby, it starts to form degenerative changes if it's been left over. So what they do as a procedure, previously they used to do a procedure through, like, they used to pass through a nail that goes through intramedullary nail or across I have shown you here, this technique is called as internal bracing. This is the recent bracing technique that they use. But prior to this, they used to put screws. What happens was, if the person, by chance, if they're not using a cam walker or the moon boot, we call it as, if they're not using that and starting to weight bear normally and start to walk, that screw can break and you can't retrieve the other end of the screw, which is on the other end, connecting to the tibia or even to the fibula. So that's the reason they've started using this internal bracing technique, which is proven to be really good and able to hold the syndesmosis much better and preventing arthritic formation in the future. So ultrasound, if you look at it, ultrasound is a dynamic examination, we all know. It directly relates to the site of symptoms. For example, if there is an ankle sprain or Achilles tendinopathy that happens, and you're trying to put the probe either horizontally or even vertically to figure out what we are dealing with, and you are able to see the projection on a film And that's what you're able to see whether the structure is injured or not. Quite often it is used for superficial structures involving your ligaments, tendons, and it's non-invasive procedure, and it uses the transducer, which is able to produce up to 20 kilohertz of sound, which we can't hear, which is above the threshold of human hearing. And the recent transducers can go up to 2 to 20 megahertz, and that's what we are using here. Even in our real-time ultrasound that we use for people to teach transverse abdominis activation, or a gluteal medius or gluteal minimus activation, or sometimes even other muscles like gluteus maximus or even hamstrings activation. We use real-time ultrasound to help people to make them as a biofeedback for them to use that as a tool. And the ultrasound transducers can be used inside the body to understand any blood vessels or vaginal for women-related issues. And anatomically, like, you can look at some internal organs. We know the major function that we use for pregnant women to understand how the baby is moving, and you are able to see a moving structure, a baby, and you are able to understand what is happening to the baby, and you are able to create information maps based on that from whatever you're seeing internally. For example, liver, kidneys, kidney stones, gallstones, gallbladder, pancreas, and spleen sometimes. So your bladder dysfunctions, and teaching people with bladder dysfunctions, you are able to teach them. So ultrasound plays a major role in all these. So here again, I want to show you how it roughly works, how ultrasound works. If you are unable to hear the audio, I'm sorry about that. I hope you're able to hear something. If you can't, I'm sorry. So here they are showing, again, it's from the National Institute. It's a 60-second video where it shows how the ultrasound works and how it emits the sound waves using the piezoelectric effect. Okay. So it's a good way to understand how much we are able to see a real-time movement of any structure using ultrasound. It uses the same piezoelectric principle, and that's what we use for our therapeutic ultrasound also. So, so if you look at it, the ultrasound indications quite often for the foot and ankle area. So we use for plantar fasciitis, any ganglions presence, Morton's neuroma, plantar plate injury, tendinopathy, any issues with synovitis. In the ankle area, we use for joint effusions, ligaments, tendinopathy, again, any neural entrapment, synovitis, capsular impingement, like a Pommy lesion, which is involving medial deltoid or posterior medial deltoid or posterior medial impingement happening due to deltoid, or the trans tibiotalar ligament impingement also, and presence of tenosynovitis in this ankle area also. So with respect to Achilles tendinopathy and the Achilles rupture, we are able to see the ultrasound plays a major role. And here is one of my client who was actually playing with her granddaughter. She's about 64-year-old person. And when she was running and playing, and the granddaughter accidentally landed on her knee posteriorly, that made her to collapse on her knee. However, her foot was completely planted, and that put the whole force onto a dorsiflexion force that ruptured Achilles, and that's what we are able to see. And this ultrasound scan image that I have put here is taken when the foot was relaxed, and you can see a separation that is happening. And the separation is more than, when it is more than 10 millimeters or 11 millimeters, it's indicated to go for surgery, because it's the muscle on the tendon have already, or the muscle tendon unit have already started to retract, and which is not going to heal, and that's going to cause a lot of problems in the future. For example, if a person who have a defect and that's going to build up a scar tissue, then the reflex mechanism for you to even to save yourself to run minimizes, purely because the Achilles tendon stiffens, or it doesn't have the same amount of force production due to slowness or sluggishness for the muscle to react from the neural conduction, due to the presence of long muscle comparing to the normal side. So we must understand when to choose, or when to advise to choose a person to go for an Achilles rupture reconstruction, or a tendon reconstruction, rather than a conservative management. It depends. Again, for certain people, we do prefer to go for conservative management versus a surgical correction or surgical repair. In the worst scenario, what happens if we have gone for a conservative management, if they go and re-rupture, then the problem is so high that you can't again go for conservative management. They have to go inside and open the Achilles and try to salvage the rest of the Achilles that was degenerated, and we have to transfer another tendon, like a flexor digitorum longus tendon. Most of the time that's what is used. Sometimes the flexor hallucis longus tendon might be used to create a stump, to create it, but that surgery will make a person unable to dorsiflex for a long time. They have to go through 12 to 14 weeks in a boot, and the initial 2 to 3 weeks in a cast, or even first 6 weeks in a cast sometimes. So we have to be mindful of this condition and ensure that we diagnose them. So clinical diagnosis, I think you all know how to do an Achilles testing or a calf testing, like a Thompson's test, to press for the calf, automatically look for the plantar flexion that is happening, where if the foot is hanging out on the edge of the table. So the otherwise, like, the other area we have to understand is ultrasound guided injections. You know, you would have heard about cortisone injections for the shoulder, elbow, for tennis elbow, for patellar tendinopathy, people with hip and gluteal tendinopathy, for corticosteroid injections, PRP injections being used, plantar fasciitis injections, plantar fibroma injections, Morton's neuroma injections, bursitis injections. So it is quite often used as a guide tool for everybody to have it. And one of the research that's happening in one of our university in Melbourne is on the Achilles tendon sheath cortisone injection. And they are trying to find between, it's a randomized study to rule out how much it helps if there is a tendon or a paratendon inflammation, and trying to settle down using corticosteroid injection. And you can also use it for aspiration. I had a patient recently post medial meniscus injury and developed a cyst on the medial side of the knee joint. And the sports doctor, I was able to see the answering tendons were able to flick on the knee joint, and referred to the sports doctor, and he called me in to show, like, you know, when he was aspirating using ultrasound injection, and after that he used the corticosteroid to help it out, to settle it down, and within 4 weeks the patient was totally okay, and there was no more flicking of the tendon on the cyst, and the cyst has completely resolved. But the person had an ultrasound guided injection, but before that he had an MRI scan taken. So we can also do neural, like, you know, nerve block can be done using ultrasound scan, like a posterior tibial nerve block can be done. Small joints, like, you know, calcaneal cuboid joints, talonavicular joint, tarsometatarsal joints can be looked into, especially plantar plate injuries, which happens at the bottom of the foot. Plantar fascia can be looked into using ultrasound guided injections also. So using PRP, like we can see how the PRP can be inserted or done for these. Sorry, I couldn't put a picture there. I couldn't get a picture which I had before. I couldn't put there in the previous slide. So PRP injections is very important, right? If someone who's allergic, I have had a patient today who was allergic to any kind of anti-inflammatories that includes medications or even a corticosteroid medications or even injections. So in those cases, like, we can use PRP, platelet-rich plasma. What they do is they take their own blood and try to centrifuge using a machine, and they have got a separate tool for it, and they centrifuge and separate the platelet-rich plasma and try to inject into the area of inflammation. And quite often it is being proven to be helpful, but it doesn't have that much of strong evidence behind it, and the papers doesn't support all the time. But anecdotally, I have seen to be having experience with this, and it has worked for certain populations or patients. So it depends on whom you're going to use what. So a CT scan basis, like, we can use the CT scan, as I mentioned to you before, for fractures, to understand any rheumatoid problems, gout, or any other type of osteoarthritic problems, joint or bony lesions, any occult fractures, any hidden fracture which doesn't show on an X-ray. For example, like an anterior process of the calcaneus, as I mentioned to you before. In a CT scan, you can see multiple X-ray images at different angles, and you can create an algorithm, and thereby you can form a 4-dimensional image or even a 3-dimensional image, and you can able to see different type of presentation of the same ankle and foot in different angle, and you are able to rotate it and you're able to see it. And the cross-sectional images are roughly about 1 to 3 millimeters thickness. So we have to understand how well we can use these, and how much we are able to use the CT scan, and how much we can miss sometimes depending on the amount of thickness of each of the image. But quite often CT scan gives us many images within the series of time. Within 20 minutes is the maximum taken for a foot and ankle, and you are able to see so many images in that. So mostly the primary use for bony pathologies, as I have mentioned, and it's more effective, but on the bone area than the soft tissues. So you are unable to find out when the X-ray absorption happening. It is unable to differentiate between a healthy tissue versus an injured tissue. For example, if there's a calf strain or even an Achilles strain, CT scan is not the preferred method, because it doesn't differentiate between the actual injured structure versus a non-injured area. So traditional versus 4D or 4-dimension or dynamic volume CT. The traditional CT involves 64 to 160 slice. Quite often, quite a few, even in Australia, we have quite a few clinics or quite a few imaging places have these, which has a small amount of coverage only of areas. But if you go for a 16 centimeter or 640 slice, where you don't need to move the table completely, or you don't need to do anything else, rather the whole CT scanner itself is able to produce the whole result up to 16 centimeter depth. So it means like a person whose foot and ankle can be completely covered, or a person of my stature, the whole body scan can be done easily without moving much on the table. Rather, the machine will automatically be able to completely take the whole image of the area that is involved. So So with respect to gout is some condition quite often we have seen, quite often misdiagnosed. How dual energy CT scan works is not, dual energy is nothing but it's the same kind of same CT scan method. What they use is they use 2 camera probe, where one sends high resolution or normal level of X-ray, and the other one is less powerful X-ray. And the computer generates both the beams and tries to get an image, and it is able to increase or decrease the amount of chemical volume that is being used. Like, for example, X-ray substance like iodine, so it's a contrast agent. You're able to see how iodine reacts to the body. So when you have any of these contrast agents being given, and then you're able to see what is happening in the foot and ankle. So this is a presentation of a gout, and we are able to see how much both the first tarsometatarsal is involved with the amount of urate crystals that are present, and that's what those red dots are showing there, how much it has affected this person's, especially the first metatarsophalangeal joint. So sometimes it can be used for kidney stone identification and for image quality. Especially like you don't want this person to expose on the CT scan or MRI scan, because it bounces back, or MRI is contraindicated with metal presence. So they go for this type of dual energy CT scan. So you are getting a better image quality. At the same time, you're able to look how whether the screws are loosened up, or whether the prosthesis that they have implanted, especially hip sockets or even an ankle replacement area, whether if it has given up, you can look into it also using this dual CT scan. So something in Australia, especially in Melbourne, we call it as a weight-bearing CT scan. This is called as, especially used for conditions like syndesmosis to differentiate how much the tibia and the fibula gap has increased between injured side versus non-injured side. Also, how they do this is if the person, as it is standing on the left side, they have put a small tape in the front. What it does is it tells how the normal ankle level of dorsiflexion or the lunge range is. So then you know, okay, that's the maximum they have done on the right side, whether this person is able to do the same level. Once they have timed or near to the same level, then you're able to create a CT scanner, and the scanner revolves around and able to create. And then what it does is it tells us a surface area. They put these two tangent line on the borders of the fibula, which is touching to the border of the tibia, both anterior and posteriorly. And this creates a surface area between the fibula and the tibia automatically, and you're able to see how much on this side versus how much on the right side. The right side actually, the left weight bearing, it's able to give you about 94, but on the right side, it is able to tell you 112.1. So that is the surface area in millimeter square. So you will know that, okay, this has actually separated the fibula away from the tibia, and automatically the syndesmosis is affected because of that. So this is one good way of understanding how a weight-bearing CT scan can be very helpful. Also, we use this for joint arthropathy, for example, in talonavicular joint, people with tarsometatarsal joint problem, people with calcaneal cuboid joint problems, any weight-bearing arthropathy, arthritis. We can also understand by doing this, we'll be able to see the normal alignment of a person's foot and ankle. In some cases, we also be able to see whether there is a collapse happening when they're weight bearing due to spring ligament weakness or spring ligament tear, and we are able to see whether the talus is collapsing or the navicular is collapsing there or not. So weight bearing CT scan is very important to understand about foot and ankle injuries, and it is in the later stages we can use it definitely. With respect to nuclear medicine plays a major role in the areas like stress fractures, stress injuries. It is highly functional, sensitive, bony problems, mostly bony pathology. It is using a small amount of radioactive substance, which helps us to diagnose or monitor or treat a disease. So for that, nuclear medicine is used. For example, radiotherapy. So the indications for most of these areas are stress or insufficiency fractures, or an occult fracture which you can't see in the normal X-ray. Detection of any subtle fractures, avascular necrosis, for example, avascular necrosis of the head or the neck of the talus, or navicular bone, or if there is a presence of infection, any bony scan, plus or minus combining with the gallium or a white cell scans also can be used, which is like agents they use, and those kind of type of scanner, which can be a bit more higher dose comparing to the normal CT they use, and bone lesions like masses, neoplastic, metastatic lesions or diseases can be also be found using the nuclear medicine. So under the nuclear medicine, what we are seeing is the bone scan, like a DEXA. So you're able to see in this, like the bone scan of the ankle and the foot, you're able to see what's happening there, whether if there is a shin problem, is there absorption of these materials on the shin area or the foot and ankle area, or the calcaneus, if there is a calcaneus stress fracture, or calcaneus complete fracture, or a talus or a navicular fractures also. We are able to look into it using the bone scan. Quite often it looks like this, but you will be able to see absorption happening. Suddenly there will be a dark spot, which I'm going to go through my next few slides. You'll be able to see that. With respect to SPECT, SPECT is nothing but a single photon emission computer tomography. It's a recent advancement as well. Like, previously positive emission tomography was used, like, positron or photon emission tomography PET scans. So comparing to those ones, like, SPECT CT scans and the nuclear medicine uses for these are really good. So in using the SPECT CT, it involves uses low dose of contrast, and the CT scan is immediately taken, or sometimes before the SPECT imaging, which uses rotating gamma camera. So we knew that the type of X-ray, the amount of exposure that the body can absorb, X-ray and the gamma rays. So using this SPECT CT scan, what we are able to do is, like, a low dose is sent, and it involves, most of the time, you don't need to have a non-contrast, like, it doesn't have to have a contrast injected into the person, and you're able to take and see what is happening in their foot and ankle. And this detects any structural abnormalities. Is there any degenerative arthropathy? Is there some other problem that is happening? What it does is, basically, it uses, again, two cameras, one with a high radiation dose, one with a low radiation, the gamma rays, and able to pick it up, and you're able to see, one gives you the actual CT image, the other is able to give you the absorption of these structures, like the radiation that happens along that area, and you merge both the pictures, and you're able to see a glowing area that tells you whether there is an inflammation is present or not. Quite often, a stress reaction, stress pain, stress fractures, early onset stress reactions from running, long distance running, people who have taken up running recently, who are not using a good proper footwear, that affects them. People with joint replacement, whether they have, due to the joint replacement, they have formed any small fractures, microtrabecular fractures due to the insertion of the prosthesis, any skeletal masses that is present, any sometimes even used for pulmonary embolism, or people with myocardial perfusion, enlargement of the heart, it can also be used for that. This is how a CT SPECT scan looks. You can see the normal CT image there, and suddenly there is an increase in the glowiness of the area, and automatically you see, okay, that's a problem there. That is the area. You can see here, that is the navicular and the first, or the medial cuneiform. You're able to see there is an orthopedic change there. There is presence of osteophytes formation. The small subchondral erosion is seen. Some sclerotic changes are seen. But that's not the problem. It doesn't glow there. But suddenly you can see there's a lot of problem here, just below the Lisfranc area. And the connections between, or the intercuneiform ligaments would have been injured, or there is a formation of arthritis there. So the surgeon can decide whether they want to go and operate this area, or whether where the exact problem is. They are able to identify and compare this to the clinical presentation. So the SPECT scan gives us an understanding what is happening there. And before these scans, always, like, we can ensure the person doesn't have any contraindications, like, exposure to radiation, or pregnancy, or children under a small, lower age category, or they have had many CT scans relating to that. And you can advise your doctor or the general practitioner whether they would benefit from having such an investigation to rule out what you're thinking for. So, with respect to MRI, what we are seeing there is, like, it's a magnetic resonance imaging. Of course, it's a large, powerful magnet that has been kept in a big dome, kind of like a donut. And in that, the patient is lying down, and they are able to see there is a radio wave transmitter is present, and there is a receiver is present. What it basically does is, the transmitter goes through. Normally, the body contains a lot of photon particles in our body, which are getting attracted to these magnetic waves. That's what the magnetic wave does. But what they do is they send an in-between signal to cut it off. Then automatically the photon waves completely turns around. And as per the movement of these magnetic waves, then these waves is converted. And when the in-between waves are stopped, and suddenly when the photon wave again turns back and towards the radiation, then that turning over is converted into an image, and that creates into an algorithm, and you are able to see the MRI slides, and that's what you're able to see in that. And this is measured using Tesla. So there are different types of, or two major types of machines are available. 1.5 Tesla is available and a 3 Tesla. Also, a recent advancement about last year or a few years back, they have made 4 Tesla. And 4 Tesla is being used in Brisbane for quite a few research methods for foot and ankle, especially, or muscle contraction, how much the muscle is able to do, whether the muscle atrophy of the intrinsic muscles of the foot, including abductor pollicis and abductor digiti minimi and quadratus plantae, and their presence and their use for after or before plantar fasciitis. And these research has been really proven to be good. So this Tesla rate helps us to understand whether it's a signal to noise ratio. It gives us a specific absorption rate and acoustic noise. Those are all the differentiation it does to tell us, like, how these images been captured. So remember, MRI contraindications, it's magnetic structures. It is always magnetized. It's a very big magnet is present there. So people with aneurysm clip, say any implants in their body, any cochlear implants, any metal sharpeners that are present in their body or around that area closer to the body, or any inferior vena cava filters are present, or aortic aneurysm, abdominal aortic aneurysm, any graft being done over there which contains actually luminals, which is actually made of metal. So any other electronic implants, cardiac defibrillators, cochlear implants, any drug infusion devices, for example, people with type 1 diabetes mellitus, they have a infusion pump inserted into the body. Sometimes it is just hanging out of a tube. We must ensure that they don't have any of those devices. Pacemakers especially, any other electronic stimulators that they have been inserted into the bodies for brain stimulation, spinal cord stimulation. People with chronic pain, they would have got a device that is stimulating the nerves directly. So ensure that this doesn't happen. This is one of the events that happened in 2014. I got to read about this a while ago when I was researching about MRI, and this guy is actually, he went with the oxygen cylinder. You can see how big that oxygen cylinder that is present, and both these two, the technician and the guy, the ward boy, they both got caught, and the oxygen cylinder was sucked to the machine, and they both were got caught there. It took nearly 4 to 5 hours for them to retrieve them out of this. And this guy had internal injury, and the other guy nearly broke his finger, I think. So we must ensure that we do the right things using the MRI. So the major indications for MRIs are any tendon problems, ligament injuries, any presence of any masses. For example, like we recently, about a week or two ago, I had a condition, a person with schwannoma, which is nothing but presence of a lot of Schwann-based masses that are present on the bottom of the foot or even in the heel area. I have seen this problem even in India also. Quite a few Indian women have this problem. And any early articular changes, for example, any first tarsometastarsal arthritic change purely because of flat-footedness, any avascular necrosis, any degeneration, presence of bone pathologies, any microtrabecular fractures. I'll show you in next few slides how are these looking in an MRI. What are all the areas that you can identify using this. So the major ligaments of the ankle, we know that you have the tibiofibular syndesmosis that is present in this area, and the lateral ligament complex, the medial ligament complex, the deltoid ligament, which we call it as, and then the spring complex, which is coming and attaching partly to the deltoid and partly it is attaching to the navicular and the talus as well. And the distal, the syndesmosis ligament, you can see like in the anterior inferior tibiofibular and the posterior inferior tibiofibular. Also the interosseous membrane, which is continuing in the middle as the intertibiofibular ligament also, which when they open through, that's when you are able to see in the weight-bearing CT scan. So a transverse tibiofibular ligament, which is the other ligament which is present at the posterior area, which causes posterior impingement quite often from a posterior ankle injury. So here we are seeing how a syndesmosis injury looks like. So this is in the for us to understand how the ligament structures posterior and anteriorly present. And here you see a normal presence of anterior inferior tibiofibular ligament and the posterior inferior tibiofibular ligament. And laterally you are able to see the peroneal tendons, the longus and the brevis that goes. The brevis, why am I saying able to see the brevis is here? Because the brevis has muscle area. So you can see you're able to see that that's a part of the muscle of the brevis which continues very low comparing to the peroneus longus. So that area is the peroneus longus. And anterior to that, you're able to see the extensor hallucis and the extensor digitorum brevis. Front to that, you're able to see the extensor digitorum tendon, and then we are able to see the tibialis anterior tendon here. And medially, we are able to see part of the deltoid area is attaching here. Okay, and you are able to see the medial malleolus. This is part of the medial malleolus. This is the plafond of the tibia. And posterior to the medial malleolus, we are able to see what all the structures here, like, your tibialis posterior, the flexor hallucis longus, and the digitorum longus presence. Okay, so that is the flexor hallucis, and the flexor digitorum is here, partly because of the muscle. The nerve is present here, and partly your Achilles and the part of your calf muscle is present also in this area. So this is the overall presentation. You're able to see how the syndesmosis, the anterior inferior tibiofibular ligament is here, and the posterior inferior tibiofibular ligament is over here, this area. And in between, you can see partly the interosseous membrane. If you go a few pictures down, you're able to see the presence of the interosseous ligament that is present. So this is like a grade 2 injury. There is a bit more stretch here. You're able to see a bit of, rather than a nice black line like this, you're able to see some scarring happening, which is a bit more grayish and a bit more thickening happening over here. And that determines, and this is a near complete injury that is completely collapsed it. And we are able to see presence of fluid here. So this is a kind of a T1 weighted image. You're able to see a presence of the fluid presence, and this is near full rupture there. We are unable to see that continuity as it is present here. So this is a patient of mine. He is a very elite professional kite surfing. I don't know whether how many of you are aware of kite surfing as a sport. I'll show you what this guy does. So he is actually connected to like a parachute type of a glide that is on top in front of him. So the wind carries him. So he is connected to a belt on his body. So there are about 3 bands that runs to the, or many ropes actually connected to it, but mainly 3 or 4 ropes that is connected to his body. And we are able to see he's connected to a surfboard or like a skateboard type of a board which slides over on the water. And this is the exact time that he did an injury. You are able to see what he does. So he's flying there, he's going like this. He does an aerial maneuver. He goes, it banged. He landed on it so heavy that he rolled his ankle at the same time and completely injured his syndesmosis and ended up in Weber fracture. Sorry, I didn't put any pictures on Weber fractures. Weber fractures are divided into Weber A, Weber B, Weber C. In this diagram, we are able to see this guy ended up in having a Weber B type of a fracture, which is above or closer to the line of the ankle or above the talus line. So for those people, there is no choice left. They have to undergo the open reduction internal fixation because the bone healing in that area ends up in either non-union or a malunion. And this guy also injured his syndesmosis. So the surgeon decided to do an open reduction internal fixation along with internal bracing. And that's what we are able to see here and bring the gutters together. And this is post-operatively what happened to this guy on his right ankle and foot. So we are able to see how an injury helps us to understand what would have happened to this person. So our aim is to ensure clinically we are able to diagnose this, and squeeze test is one of the tests that we do, a squeeze test for between your shin bones, and external rotation test of the ankle also, either in supine position or in a prone position. So you can see the next is the deltoid ligament complex, how it looks in an MRI. The deltoid, you can see the talonavicular part of the deltoid, then the superficial and the deep layer of the string part of the tibio spring ligament complex area, then the tibio-calcaneal part of the deltoid, and the posterior tibiotalar ligament, which are all the whole complex of the deltoid ligament along with the spring ligament that is present, which is like connecting to the calcaneonavicular ligament area. So when a person injures it, you can see how the ligament is present, which we are able to see connecting to the talus, and then we are able to see how the medial structures are present. There is a bit of a periosteal avulsion here, so we are able to see that is separated. It is not continuously or connected to that, and this area is like thickened, partly the periosteum is more thickened post that injury, and we are able to see a bit of flexor retinaculum is also involved over here. So we must understand from this, quite often if a person who's ending up in an inversion injury, there is a high likely chance of injuring the deltoid ligament also. So please don't miss it. We always think that anterior drawer test involves only lateral ligament involvement. That's not the fact. It is connected. The talus is connected only by ligaments. We all know that there is no muscular attachment or tendon attachment to talus. So the anterior drawer test tests not only the lateral structures or the lateral collateral or the not the lateral collateral, the anterior talofibular ligament, but it also assesses the deltoid ligament. So we must ensure we are able to test both of them and feel both of them in clinically. So that gives us an understanding what is happening, and then we can refer them either for X-ray or ultrasound scan or even for an MRI further. So here, furthermore, I have shown some pictures how these ligaments are present in an MRI. Sometimes we are given films. It's very hard to go and look into those films. If you can request your patient to bring at least CD or a memory stick, and you're able to load that in your computer, you can zoom that, and the platform will allow you to look at in your computer, and you're able to see it. And always request your patient to get a CD of the scans taken. Obviously, the report will also be given by the radiologist, but it's good to go and look into it. Here we are able to see a spring ligament involvement here, and this is one of my patients who heavily landed on their foot, and they completely injured their spring ligament because the pain. We thought that they have developed plantar fascia. Here we can see a thin line that how it goes like at the bottom of every other muscle here, and we are seeing that that's the plantar fascia. The rest is all the fat pad that is present along the heel area. You're able to see the posterior Achilles bursa. Then we can see a bit of retrocalcaneal bursa that is present here. Then the Kagas fat pad that is present in front of the Achilles. Then we are able to see the lateral process of the talus, the dome of the talus, the neck of the talus, the body or the head of the talus, the navicular, the medial cuneiform, the tibia, the presence of the plafond, and how it is the dome is articulating there. The nice white line, we call it, it's like the third day or the second day of post Black Moon Day, we are able to see how the moon ring is forming there. So the same way we want to see a ring that is forming on the dome of the talus. So that helps us to understand how these structures are present. I'll show you in the next few films like how a talar dome lesion is present also. Here we are able to see a lateral ligament injury of the calcaneofibular or the lateral ligament of the ankle. Which shows us like how it's like a grade 2 injury. This is a normal alignment. You can see how black and thick it is, but here it is smudged and bit of gray lines is present. Here you're unable to see the ligament at all. It's a complete ligament injury which is completely sprained. Over a period of time, these kind of people will develop arthritis in their ankles. So ensure that when you do the test, if there is a positive presence is there, better to have a consultation with an orthopedic surgeon along with the patient. If there is only one ligament involved. If it is more than one ligament involved, other than your CFL, if there is a ATFL is involved or even the deltoid is involved, better to go for surgical correction to ensure the ligaments are kept together, and that prevents them from developing arthritis or some other problems in the future. Here it's one of the MRI of an young patient of mine. She's only 16-year-old. A full-on runner, a long-distance runner, ended up in rolling her ankle, landing on a small rock, and developed this anterior ankle pain. And when I was assessing her, she was very tender on the end spot or the junction of the end spot on the head of the talus. Sent her for X-ray. Initially, X-ray didn't rule out anything, but MRI did show us presence of microtrabecular fracture of the head and neck of the talus. Also, injury to the ATFL. We can see how the ATFL is present here. You can see it is completely hypertrophied now. It is not a black line anymore, and that shows us like this person has had an ankle injury in the past. So she is still in the moon boot at the moment, or Cam Walker. We are expecting her to be off from that in the next week or two. So here we are seeing a CT scan guided corticosteroid injection, how it can be inserted, how it can be beneficial for us to understand how it works. This patient of mine had a multiple community fracture of his calcaneus and underwent conservative management. However, he developed a lot of pain on his sinus tarsian and the subtalar joint. His inversion and inversion were completely limited also, and his walking on uneven surfaces or walking along the beach was very hard. So he underwent corticosteroid injection using CT scan guidance. These white dot marks are the markers. They try to mark that area on the medial and the lateral area, try to insert through from the medial, posterior medial aspect to go into the subtalar area and inject corticosteroid solutions there. So here is a slide that I'm showing you. Hope you all able to see this. I don't know how many you're able to see it, but if you're able to see fully, there is a fracture here. Due to time constraint, I don't want to pull too much of time on this, but what I wanted to show you was this is where the fracture is. It is called as the Jones fracture of the 5th metatarsal. Where we are able to see this person was a basketball player, landed very heavily on the outer side of the ankle on a grand final or the final game, and had to have a procedure done to put some screws to stabilize it, because the Jones fracture doesn't heal itself. They have to undergo surgery for this. So I thought of showing you this, how X-ray is so beneficial to understand the different view, like an oblique view and a lateral view is what is shown here, and we are able to see how clearly this fracture is seen in this area. And we are also able to see how the subtalar joint is present, how the talus is overlapping on the calcaneus process anteriorly, so that limits are unable to see the anterior process of the calcaneus also sometimes. So we are able to understand how X-ray viewing plays a major role for physiotherapists to design our management and further program like short-term goal and long-term goal to return them back to their sport. So with respect to hallux valgus, this is one of my patients, the same guy who had the Jones fracture. We can see any person who has hallux valgus more than 15 degrees of angulation, then we call it as it's a hallux valgus which is beyond, and there is an overlap happening. Here we can see how the skin is overlapping, or the soft tissues are overlapping between the second and the first toe. The second toe is wanting to go under the first, the first toe wanting to under the second toe. So we can see that the angulation is more than 15 degrees, nearly 27.2 degrees there. And this shift is happening at the metatarsal level and not at the metatarsal phalangeal. The metatarsal phalangeal is the sequelae or the secondary effect due to the primary change in the first metatarsal change. So what the surgeon did was, like, he had an MRI scan to look. This is another patient of mine. I wanted to show you this. This is a 37-year-old person who have had a plantar plate tear, which is happening at the bottom here. And she also had the hallux valgus, and the surgeon decided to do a procedure. Here we can see what they have done. It's called as the osteotomy procedure. Also an Aikins osteotomy of the proximal phalanx. And when they have done it and they have fused it and put rods through, also they have fixed the plantar plate injury on the second and the third toe on the left side. And we are able to see how this imaging helps us to understand what has happened to this person, and we can design, okay, the main aim I had to keep for this person was to ensure the tarsometatarsal joint and the metatarsophalangeal joints are moving really well, able to get the whole dorsiflexion, the plantar flexion, also the foot and ankle movement, and able to do a calf raise comfortably on one leg. So this person undergone this procedure about 6-7 months ago. Now she is in a position to do box jumps, and she is able to do single leg calf raises 32 times. And these are all the kind of area for us to understand where the person has progressed. And 4 months ago, when we had another X-ray taken, that has been far better than what it is present in this situation. So here we are seeing the Morton's neuroma, how a Morton's neuroma on the bursitis that is present between the shafts of the second and the third and the fourth is quite often seen, and the bursitis is starting to compress on the nerve starts to devoid of blood flow in that area and starting to form a fibroma presence, and the neuroma starts to throw pain and pins and needles or numbness or a lot of pain along the second and the third, or the third and the fourth quite often. But this person is also having some bursitis that is present between the first and the second, and we are able to see active inflammation presence in this area and the fluid presence also. So MRI guides us to understand what is happening. Quite often we think that it could be sesamoiditis or some other problem, or even a plantar plate injury, but yeah, this helped us a lot to identify what is happening, and reading of images is very important. Here I am showing you again on Achilles rupture, how the Achilles rupture is seen in an ultrasound scan, and what difference it is giving us to understand, and how early this person needs to go and see a specialist to decide whether to go for conservative or a surgical management. And this is a person of 44-year-old guy who came and saw me. The left X-ray was taken about 8 years ago. He was developing some heel pain, but he kept ignoring. However, he had some lateral ankle pain also closer to the peroneus brevis insertion. Then we found out that he was developing os peronei, which is a bone ossicle forming at the outer ankle closer to the peroneal insertion that was rubbing on the tendon, and that started irritating him more and more. However, he had an X-ray taken in January this year, and we are able to see the enthesopathy forming, and the retrocalcaneal bursitis bursa was present, and the bursitis was present. Lot of pain. Achilles tendon was completely inflamed, and we are able to see in the MRI how it is present. You can see the bulge and the swelling. The cagus pad is irritated and inflamed. The posterior ankle is full of swelling, and the retrocalcaneal bursa is inflamed also, which is present here. And we are able to see the enthesopathic change, where the part of the calcification of the Achilles tendon have happened at the Haglund, and he is forming something we call as a Haglund deformity. We would have read in Natarajan's book in orthopedics about Haglund's deformity. So we are able to see that in real time. So this person undergone Achilles repair, along with removal of these bony structures, and he's about 4 months into the procedure. Is out of the boat. So here we are able to see a person. She is about 130 kilograms weight. A person of my tall, 6'1", and 130 kilograms. Rolled her ankle about 5-6 years ago, but completely misdiagnosed with an avulsed fracture of the styloid process of the base of the fifth metatarsal. This is not a Jones fracture. This is different to the Jones fracture. The Jones fracture happened here, just above the base, or closer to the junction between the metatarsals shaft and the base. So this tells us understanding, okay, this person underwent surgery and peroneal reconstruction also, and felt much better, and the pain was completely a lot better. And this is the POMI lesion. We call it as the posterior medial impingement, that is called POMI, which is purely because of the posterior deltoid is involved, that causes a lot of scar tissue formation that starts, and we can see this is an arthroscopic view of it, and that's stops it or getting impinged all the time. So they have to undergo a posterior medial arthroscopy to take this scar tissue out. Sometimes they have to do a small capsulotomy or a capsulorrhaphy to clean up the whole posterior area. But this procedure always backfires. Quite a few people struggles a lot to do a knee to wall movement or the lunge movement post this procedure. So the talar dome lesion, here we can see what happens. This is post an ankle sprain, completely missed again in an X-ray. So this person was having pain even 3 months post his ankle sprain. He was not recovering. He is unable to weight bear properly, unable to do calf raises, or able to prolong standing. So we send him for an MRI. As I was talking to you before, the moon sign or the nice ring sign there, half ring that is completely lost here. We can see subchondral fracture presence and presence of fluid and the discontinuity of the cartilage of the talus dome. And this helps us, like, this is a complete talar dome lesion. So through imaging, we are able to know, like, what imaging is important for what conditions. I couldn't put all the conditions here, like a SPECT CT scan is what I have shown you here, how it glows up here. Using that procedure, here we are able to see a person with the first metatarsal fracture on the shaft, a stress reaction, stress response. So X-ray plays a major role as the first line for us to understand. Quite often we are unable to find out if your clinical correlationship is so high, you can send this person for either ultrasound or further imaging like CT or a nuclear medicine for CT specs. But you can mention it in your letter to the orthopedic surgeon or even to the specialist or the doctor, saying that this is what you suspect with your patient from your clinical finding, and you can guide them, and that will help them to take it further. And this will also help us to understand what kind of injury you're dealing with, and this will help us to plan your intervention or plan your goals for this patient, how long they're going to see you, or what type of exercise you can do at what stages, or whether this person needs recurrent exposure or recurrent investigation taken. So thank you so much for your patience. Sorry, I've slightly extended my time. It's a bit of a different topic, but thank you so much for your patience and to listen to this.
Thank you so much, Mr. Sathya. Really wonderful session, actually. It was like remembering a lot of things. Almost not only a lot of things, I have learned a new terminology also, like dual energy, SPECT, nuclear medicine. I hope Rupesh will agree with that. And we have learned about book ethics. Whatever we have studied, it was like, once again we have gone through that. You wonderfully explained not only the imaging thing, you explained conditions also. That's a very, very, very fine part of it. I hope the students who attended will enjoy it, and they are going to write exams also by next month. Many of the students, it will be helpful for them to understand their ankle and foot injuries. And by this, we will move on to question and answer session. And if Rupesh, would you like to speak any few words?
Yes, it was actually an eye-opener for ankle and foot radiology, actually. So
thank you.
Many people will not share this much in this open platform. So you have done that great thing of sharing of knowledge. So thank you very much on behalf of all the participants. So thank you.
Thank you so much. Thank you for the invite, actually. Much appreciated to you all. Thanks for conducting this. This is the second one. I was very excited, actually. I want to present it much better than what I did the first time. So pressure is on me so that I keep up with you all, actually.
Wonderful. This is a great session. Okay, we will move on to question and answer. Dear participants, if you have any doubts, please write in your chat box. Those who are watching in YouTube, you can write in your comment box. We will read it here. So please, can you please check in YouTube?
Yeah, sir, I will check. No questions in the YouTube. Any Zoom viewers, you can place your message in the chat box. And many appreciations in the Zoom chat box. Like, thank you and very informative session.
Thank you.
Any questions? Yeah, first question has raised, sir, from Ms. Justin. What is the difference between sensitivity and specificity, sir?
Okay, I'll tell you from a physiotherapy point of view, with most of the research that we look for is whether that the test that we do, whether it is sensitive or whether it is specific. For example, we're going to do an anterior drawer test for an ankle, all right? So when we do the anterior drawer test, the patient says, okay, they've got pain, but we are unable to know what structure is involved there during an anterior drawer test. A lot of structures are involved, as I mentioned to you before. So a deltoid ligament at the medially, or lateral ligament structures laterally. So it is not as specific as to know what structure is involved. So, but it is highly sensitive. The patient is able to say, okay, they've got pain in that ankle area. But for us to differentiate it, we have to go and palpate that area further. But that ligament test doesn't tell us what the structure is involved there. On the other hand, if we look at the sensitivity and specificity of certain tests, is a Lachman's test for ACL. So when you do a test to do an anterior drawer test, the sensitivity is as equal as specificity there. You are able to feel the end field, whether the ACL is present or not. And that end field will determine you whether this person has done the ACL or not. So this way, you are able to know whether the structure that is involved is very specific. You are able to say, okay, this structure, this test tells us this area is involved. I'll give you another example. When we do a slump test for lower back, the slump test tells us there is an involvement of sciatic nerve, but it is sensitive then, okay? It shows the person is able to say, okay, I've got the same sciatic referral pain. I'm able to feel through the posterior leg, through up to the foot and ankle area. But we don't know which part of the sciatic nerve root is involved. We don't know whether it is L4 level or S1 level or S3 level. We are unable to differentiate it. So it is not specific. So that is the difference between sensitivity and specificity. I hope I have answered it.
Yes, sir. Thanks for the explanation. And again, few appreciations in between. And next question is from Mr. Panduranga Rao. The question is, sir, any other clinical prediction rules like Ottawa ankles rules, sir?
Yeah, that's what, as I mentioned before, for any ankle injuries, we always try to follow the Ottawa ankle rules. That's the gold standard. It has got a high level of specificity, because you try to understand what structure is involved, and you want to rule out whether there is a fracture is present. For example, a Weber fracture in case of an ankle, or the lateral malleolus, or if there is a medial malleolus presence. For sure, if there is an ankle dislocation, if the ankle is hanging out from a road traffic injury, and you know it, okay, this is an injury, and we have to send them for X-ray or further investigation to be done to rule out what is happening in that area. But an Ottawa rule will tell us whether the person has to undergo an X-ray or not. So as a clinician, we are able to minimize the person exposing to X-ray, or whether they need further investigation, or whether it is just a sprain that can be managed conservatively. And that's what we are ruling out in all these kind of management, or as a clinician. As a physiotherapist working, we are all primary practitioners. Even in your practice, quite often, or future students who's going to be as a physiotherapist, you will be seeing your uncles and aunties, okay, they were walking and suddenly they slipped, or they rolled their ankle, or they slipped and hyperextended their knee, or they landed on the hip. And you want to go and rule out what is happening. They come straight to you, hey, so-and-so person, can you check me what has happened? I don't know what is happening to me. I've injured my ankle, I believe, and I don't know whether it is just a sprain or it is something more than that. When you assess them, that will tell you what you're ruling out and ruling in. And that level of understanding of Ottawa rules will tell us whether to send the person for X-ray or not.
Yes, sir. Thank you, sir.
No problem.
The question are not there. Again, there are few more appreciations. Thanks for the wonderful informative session, sir.
No problem.
Yeah, sir.
Anytime.
Any questions, participants or YouTube viewers? You can text your questions in YouTube chat box, live chat. Chandramohan,
Kindly check once in the YouTube. If there is no questions, we can shine off.
Yeah, sir, we can. Sir, one more question from Ms. Nurul Afrin. Can you explain sprain seen in MRI?
Okay, I'll just go back to my sharing my picture once again, if you don't mind.
Yeah, sir.
Okay, so here I'm going to show you a lateral ligament injury, which I showed you before. This is the MRI, the T1 weighted image and a T2 weighted image. A T1 weighted image will tell us, like, the bone structures and the soft tissue structures, so it reverse, it looks like in a grayish, versus the fluid structures will be looking much more darker. All right. In a T2 image, the bone structures and the soft tissue structures will be much more darker, and the fluid structures will be much more whiter. So it'll be able to glow. That's what you're seeing. So here we are able to see the glow in the bone. Like this is a subchondral injury. We are able to see that's a trabecular fracture there. So just underneath it, we are able to see a spring ligament is present there. That is the head of the talus, and we are able to see the spring ligament. We always study about spring ligament and other structures, how it is beautifully looking in the MRI. We are finding to understand it. We go directly laterally here. I'm able to show you this gray line that is present here. That is the ATFL, which is the anterior talofibular ligament. So quite often a sprain injury. So if a person who is standing and then they roll or inversion sprain, what happens in the outer side of the ankle that is connecting from the tip of the fibula anteriorly to the outer side of the talus to the body, that's the ATFL presence. So it pulls the ligament. The ligament have the tensile property, but when it goes beyond their capacity, then the load strains or sprains them. So that tears them. So that tear is differentiated again at a, initially we used to call it as a mild, moderate, severe, or a grade 1 or a grade 2 or grade 3, minimal injury, partial injury, or a full injury, or a grade 2 injury, or a full thickness injury. So there are so many different presentations there. So you try to sometimes compare to the normal side and try to do a justification here by understanding what is happening. But an MRI scan, they will allow only for one side because it is highly expensive. You can't put both the ankle as a comparison. However, you're able to understand when you look at the film, okay, all right, this is the ATFL that is present. So on the left image here, I have got is the calcaneofibular ligament, which is the lateral ligament attaching from the tip of the lateral malleolus to the outer portion of the calcaneus. So here we are able to see the dark presence of this structure, and when it gets injured, half becomes dark and the other half becomes more grayish presence in the T1 weighted image. And the last picture here, we can see it's a completely disrupted here. There is no continuity of this ligament. So you can see this line that is present here is partly injured, but previously the line is much more darker and fully present here. So that determines you are able to differentiate a ligament injury versus any other soft tissue injury. For example, if you're able to see a presence of a ring of fluid within this black hole here, so that is partly your peroneal tendons that is present here. Then we know, okay, there could be some injury to the tendon itself if you see white lines in this area. So you are able to differentiate them between a ligament presence versus a soft tissue presence versus a tendon presence or some other structures like cysts are forming. I hope I've answered you.
Yes, sir.
Nurul Afrin got the answer. Any other questions?
No, sir. No questions in YouTube also, sir.
Okay, wind up now. Okay.
Yeah, sir.
Yes, a very wonderful question and answer session also. I take this opportunity to thank Mr. Sathya on behalf of all the participants and our Fitness and Rehab India YouTube viewers. And I thank Dr. Rupesh and Professor Duna for their help. And thank you all. And we will be posting questions in the WhatsApp group. kindly, not questions, we will be sending the link and go through the link through our website and answer the MCQs and download your certificate within an hour. Thank you all. Good night. Bye-bye.
Thank you, Chandra.
Good night, sir. Bye, sir. Thank you very much, sir.
Thank you.